Hello friends, welcome to another session of Radio Shots, and today we'll be discussing a very interesting case from abdominal imaging. Now this is a case of a 24-year-old gentleman who came to us with history of trauma. Now this trauma was significant. Patient gave a history of fall from the roof and so naturally he was being sent to us for an E-fast examination. I hope all of you know what E-fast is. We just wanted to detect any fluid in the peritoneal cavity to confirm or rule out presence of a visceral injury. The patient also gave a history of pain abdomen, which make the possibility of an abdominal visceral injury more likely. So this is the sonographic cine image of the patient. I want you to have a look at it. And the images are being taken from the epigastric region in the midline, and I'm slowly maneuvering the probe in the more quarter direction. What do you see? I hope all of you will be able to see that there's something gone wrong with the aorta in midline. We can see the aorta is here, but all around the aorta, there is this soft tissue. Let me play this video in a much slower fashion in which you can see that the branches of the aorta, this is the right renal artery, this is the left renal artery, they appear to be splayed over by the lesion. Also, we can see that these are the anterior branches. The SMA is also shifted more anteriorly, and the aorta per se has also been moved anteriorly. You can see this is the vertebral body. So there is some retroperitoneal pathology. Why it's a retroperitoneal pathology? Because not only it's encasing the aorta, but it is also displacing the aorta anteriorly. We do have a retroperitoneal lesion. Patient is coming to us with history of trauma, pain in the abdomen. What do you think of? Can it be a retroperitoneal hematoma? Probably or probably not. What can we do? We can put a color Doppler in to find any more information that we can get. Now, I want you to have a look at this color Doppler image of the patient and tell me what you can make out of it. So when we put the color Doppler in, the lesion per se is not showing significant color flow, but we can see the vessels which are showing completely normal color flow. So there is a pathology in the retroperitoneum which is encasing the great vessels, encasing the branches of the great vessels as well, but it is not causing luminal compromise. Let me play it again to show you the different branches of aorta. So here you can see the right renal artery and the left renal artery. That's the left renal artery, and I'm maneuvering here slightly on the right side so I can also see the right renal artery here. So this is the right renal artery. When I'm going more superiorly or cranially, I can see the origin of the superior mesenteric artery. I can even see these iliolumbar arteries being originating from the aorta, and they also have been pushed more anteriorly by this retroperitoneal soft tissue. One more important observation that I could make on the sonographic image is when I'm maneuvering my probe very superiorly, like in the epigastric region, and I'm just pointing it cranially, I can see this soft tissue is extending up to the retrocrural region. I can't say that it's extending in the thoracic cavity, but definitely I can say it's extending through the level of the abdominal hiatus into the retrocrural space. So now I ask you, what is your likely diagnosis is? I still thought that we're dealing with a case of some retroperitoneal neoplasm. But the surgeon said, how is it possible that a patient is coming to you with history of trauma and you're diagnosing a retroperitoneal neoplasm? Why don't we think about common things first, which are retroperitoneal hematoma in this case? I said it doesn't look like a retroperitoneal hematoma, but again, you know, surgeons, they don't agree to what radiologist says. So the patient was sent to us for CT scan of the abdomen. So then let's have a look at what did we find on the CT abdomen of the patient. So here are the CT images of the patient, and this is a cine loop that I'm going to play from top to bottom. So in the chest itself, we can see that there is some amount of pleural effusion present bilaterally. And as we are entering in the abdominal cavity, we can see that particular finding that I could make out on the sonography as well. Now you can see that there is this soft tissue mass lesion which is present in the retrocrural space. And as we're going down, this soft tissue is now seen in continuation with the larger soft tissue which is present inside the retroperitoneal compartment. Now, here exactly, I want you to have a look at the aorta. This aorta is present here. This is all that soft tissue. The IVC has been pushed so far apart anteriorly. This aorta also has been pushed from its native position because now we can see that there is a soft tissue which is lying posterior to the aorta between the vertebral bodies and the aortic wall posteriorly. So we're dealing with a mass lesion which is a retroperitoneal mass lesion. Why I'm saying it's a retroperitoneal mass lesion? Because we can see that this mass lesion is displacing the aorta anteriorly. Let's have a look at the effect it's causing on the other vessels. So here we can again see the left renal artery being stretched and splayed over the lesion, and similarly the right renal artery also being stretched. It appears to have been elongated, but at the same time, Look at the caliber of the vessels. The caliber of the vessels is perfectly normal. I don't see any significant luminal narrowing. I don't see any thrombus extending to the vascular lumen either. When we talk about the SMA, look at the SMA itself. The SMA also appears to have been stretched over the lesion, and we can see that there is an increased distance between the aorta and the SMA, that is the aorto-mesenteric space. When we go a bit down, you can also see that both of these iliolumbar arteries very well seen. So all the ultrasound findings that we could see are being mimicked on the CT image as well. Let's go down a bit. Now here when I'm going towards lower aspect, I can see that there are areas which are not showing avid enhancement. Rather, they appear hypo-enhanced as compared to the relatively homogeneous enhancing soft tissue which is present all throughout the retroperitoneum. This means that there are areas which are showing some cystic degeneration, some necrosis within the lesion. One other important finding that you can also see is there is no calcification in the lesion. I don't see any calcium within the lesion. Now, I'm going further down, and when I'm going at the lowest part, I can see that there is some fluid in the peritoneal cavity, and that's not all. Let me just clear this mess up for you. I can also see that there is some soft tissue which is lying in the pelvis. Also, we can see that there is smooth enhancing peritoneal thickening in the lower abdomen, but the soft tissue appears to be very homogeneously enhancing, quite similar to the enhancement that we saw with the primary retroperitoneal lesion. And it is seen separate from the rectum, so it doesn't look like a rectal growth because rectum is seen separate and it appears to be compressed posteriorly by the lesion. Now, my question to you is, what are your differentials? Does it look like a retroperitoneal hematoma? No, it doesn't look like. In fact, it looks like an enhancing retroperitoneal mass lesion. But before we come to our conclusive diagnosis, let's have a look at the same case by different projections. So first, let's have a look at the coronal images. So this is the coronary reformatted CT. Again, this is a video being played from anterior to posterior. What do we see here? All the findings that were apparent on an axial view are also seen well on the coronal view. The coronal view, however, shows us the aorta, the branches, the IVC in a much better fashion. Look at this IVC. It appears to have been distorted as if it has been floating around. Similarly, the aorta also appears to be floating in this sea or in this ocean of the soft tissue that you can see. So this type of a sign, I hope that many of you would be able to remember, is called as the floating aorta sign. Floating aorta sign. Before we end it, let's have a look at the sagittal deformation also. In the sagittal deformation, what we're getting? Again, the similar findings will be seen well on the sagittal deformation. You can see that this lesion is very homogeneous. This lesion is retroperitoneal location, doesn't show calcifications, shows some inflammatory fat stranding in the adjoining retroperitoneal tissue, and it appears to encase the vessels but not invade them. So these are the most important cine images. What you can see here. Again, we can see that this mass is retroperitoneal. Why? We've already discussed this because the aorta is anterior. We can see the kidney is also showing massive effect. Now, because the aorta is being pushed anteriorly, the renal arteries are being pushed anteriorly, it appears as if kidneys are hanging over this particular lesion. You can also see that the IVC, again, it appears to be floating in this lesion. The pancreas is displaced anteriorly, something we expect for a retroperitoneal mass lesion to do. And the similar findings can be further seen on the coronal view. In the coronal view, you can see this floating renal artery, something which I've been forcing again and again. This is another image from the same patient. Now in this image, we can see that there is this soft tissue deposit is further extending up to the mesentery and it is encasing the mesenteric vessels in a lower part of the abdomen. So this sign has been given a fancy name called as sandwich sign. So we have two important signs that we've seen in this particular case. One of them is the floating aorta sign that we talked about. Now there is a mass lesion which is seen in the retroperitoneum, which is encasing the great vessels, and the great vessels appear to be floating within them. Number two, you can also see that there is this sandwich-like appearance. In fact, initially when this sign was described, it was described for mesenteric nodal masses, but this sign is now further extended to involve both the mesenteric as well as para-aortic nodal masses, which tend to encase the mesenteric vessels, and this gives rise to this shape of a hamburger or a sandwich. So these two signs are quite specifically seen in retroperitoneal mass lesions. Now, do you think that it is a retroperitoneal hematoma? Coming back to the query of surgeon, is there a chance that it is a retroperitoneal hematoma? No, it doesn't look like a retroperitoneal hematoma from any angle. So the next question is, we should be knowing how does a retroperitoneal hematoma look like. So now let's have a look at our next CT. And again, this is a cine loop, and we're seeing the CT abdomen of the patient from top to bottom. We can see some fluid in the perihepatic space, some fluid in the perisplenic region. And as I'm going down, let me just fast forward this clip for you. What we see here is that there is a lobulated soft tissue mass lesion which is present in the left side of the abdomen, in the left iliac fossa primarily. If I ask you this lesion is an intraperitoneal or retroperitoneal lesion, then we have to look at the retroperitoneal structures. Look at the kidney. The kidney appears to be slightly displaced anteriorly, but that's not all. We can see that the Zucker canal fascia. So that's a Zucker canal fascia that's also displaced along the anterior aspect of the lesion. So this lesion is definitely retroperitoneal in location, extending into the posterior paraginal space. It is seen just anterolateral to the psoas muscle. And as I'm going down, so you can see that there is some amount of inflammatory fat stranding in the adjoining pelvic side wall as well as in the pelvic peritoneum, plus some intraperitoneal fluid as well. If I just show you this in a loop, probably your diagnosis is going to be again a retroperitoneal mass lesion, maybe a malignancy. But, and there is a big but, I want you to have a look at this image again. But now what I'm doing is I'm now showing you the non-contrast image of the patient alongside the post-contrast image. So you see carefully, this lesion is appearing hyperdense on the non-contrast image as well. And if you compare the non-contrast and the post-contrast attenuation values, you don't see any significant enhancement. Look at it, how hyperdense it is on the non-contrast scans. This is a classical example of a retroperitoneal hematoma. Now, this is a patient who was on anticoagulants, and this patient had a trivial injury after which there was development of a left-sided lump in the abdominal cavity. Ultrasound was done, which showed some soft tissue, and we did a CT scan, which confirmed that there was a retroperitoneal hematoma in this case. But this lesion is definitely not looking like the lesion that we've just seen. But this brings us to one very important question, the importance of a non-contrast scan, which we haven't looked at. So let's have a look at the non-contrast scan again of our patient. This non-contrast scan of the patient is not showing us any hyperdensity. Secondly, there is a clear-cut enhancement of the lesion after we've given contrast administration. Now, this completely rules out the possibility of a retroperitoneal hematoma. So, what are the findings in our case? Our findings are number one, a retroperitoneal mass lesion. Now, whenever you're reporting such a case, you have to explain the mass lesion starting from the location. So obviously the location is in the retroperitoneal lesion, but it is extending in the retrocaudal lesion as well. You have to give the craniocaudal extent of the lesion. You have to tell whether it's extending up to the level of aortic bifurcation and going further beyond it or not. Then second important thing, you have to tell about the encasement or the mass effect. Now, when we talk about the encasement or the mass effect, we've already discussed it in great detail that this lesion is causing encasement of the great vessels of the aorta. I'll just write it for you: aorta, IVC, renal arteries, SMA. So these are the major vessels which are being encased. There is one complete encasement. I should say there is 360-degree encasement of the vessels, but there is no luminal compromise. No luminal compromise. Now, many a times what we do is we tend to garnish our reports by writing fancy names of signs. So you can also write the names of the signs. We have floating aorta sign, plus we also have a sandwich sign. Next important thing is some important positive findings in order to characterize the lesion. So we do see some non-enhancing areas, which may either represent cystic changes or may either represent necrosis. And a very important negative finding is absence of calcifications. Finally, we have a deposit in pelvis plus ascites. So in short, these are the most important findings that we can take from our case. So the next thing is, what is our provisional diagnosis? So our first provisional diagnosis was lymphoma. Why? Because all the features were favoring lymphoma. We had a retroperitoneal soft tissue mass lesion, which was pretty much homogeneous, which was not showing calcifications. So we had a homogeneous mass lesion, and it did not show calcifications. We don't see calcifications in a patient with lymphoma. Secondly, we had some other features like the classical signs that we saw, like floating aorta, like sandwich sign, which were pretty much making things quite clear. Secondly, we had a retrocrural involvement, which is also seen in case of lymphomas. We had bilateral pleural effusion, ascites, which is also one of the feature that is seen with lymphomas. Now, what is the thing which was against lymphomas? The thing which was against lymphomas was those suspicious necrotic areas or cystic areas that we were seeing. The age again was not pretty much supportive because now we were dealing with a case of a retroperitoneal lymphoma, which is usually a non-Hodgkin's lymphoma. So this was one thing which was going against. The other differentials that could be taken up were number two, retroperitoneal sarcomas. What are the retroperitoneal sarcomas that you know about? I hope that you might be knowing about leiomyosarcomas. You might be knowing about liposarcomas. You may be knowing about MFH, that is malignant fibrous histiocytoma. So these are common things, but again, they're more infiltrative, much more irregular, heterogeneous, showing areas of necrosis and invasion of the vessel. So all these things were not present, so we didn't think of any of them. Last, did we keep a possibility of a retroperitoneal hematoma? No, I did not keep a possibility of retroperitoneal hematoma in this case at all. Why? Because this lesion was not looking like hematoma, it was enhancing lesion, and probably the history of trauma in this case was just incidental. Now comes the important part, biopsy. And the biopsy of the tumor revealed it to be a metastatic tumor. Now we were shaken because we were pretty much sure we saw everything that we could see in lymphoma and we thought that we we're dealing with a case of lymphoma, but biopsy had something else to say. Now what to do next? Now it's a metastatic tumor, and a metastatic tumor in a young male which is presenting in form of significant retroperitoneal lymphadenopathy, retrocrural lymphadenopathy, ascites, pleural effusion, plus a deposit in the pelvis. What do you think would be the possible primary? Now, to understand the possible primary, we went back to the CT again. We tried to dig out, search something, and there was something in the CT that we're missing till now. Let's have a look at the CT cine clip again. So this is the CT cine loop, and now again, I want you to have a look at it in very close discretion. So in the abdomen, I think we picked all the findings. We could not see any primary in the abdomen. But when we were going down, 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 and we are reaching this level, what do you see? Do you see anything? Now we were able to see that there is left spermatic cord, which is present. But on the right side, do you see any cord? No. Let me just go back. I don't see the cord here either. So when we asked the patient, he said that there was a history of some scrotal swelling, some testicular swelling 1 year back, for which he had undergone a surgery and he did not remember anything out of it. So now the things were becoming clear when we were actually trying to fill in all the blocks of that jigsaw puzzle. Probably this patient had had a testicular malignancy, and whatever we were seeing in the retroperitoneum was nothing but a metastatic lymphadenopathy. The primary must have been in the testes. So now there are three important lessons that we can learn from this particular case. Firstly, whenever a young patient comes to you with a retroperitoneal mass lesion, a retroperitoneal lymphadenopathy, always look at gonads. However, in this case, the patient came to us with a history of trauma, so we never thought about finding anything in the gonads. But had we looked at the gonads, had we did a screening sonography of the gonads, the picture would have been a bit different. Second important thing to learn from in this case is that we should not moved away by fancy signs and names like floating aorta sign, like sandwich sign, because when you go back into the literature, this floating aorta sign can be seen in cases of malignant retroperitoneal masses also, can be seen in case of Castleman's disease also, can be seen in cases of sarcomas also. So we should use our brains and we should look at the entire patient as a whole rather than looking at one particular finding and making a diagnosis based on one fancy name. Last but not the least, always give a broad list of differential diagnosis. In our case, we gave only one diagnosis, retroperitoneal lymphoma, but we should always give differentials. You could have given a possibility of metastatic lymphadenopathy in which the things won't have made much of a difference, but still we could have been to a certain extent correct. So with this, we finish our discussion on this interesting case of a retroperitoneal mass lesion, which eventually turned out to be a testicular metastatic lesion.